after a minor scooter accident. When I inquired who lifted him from the road in an unconscious state to the hospital, then it was mentioned that he himself got up and drove the vehicle back home. If you had taken the first sentence, that I fell down from the scooter, then I regained consciousness in the hospital, then you think that patient was really unconscious. But when you take the history from the attender, then you know that he was conscious, but he does not remember. Now this is called as amnesia, that is the post-traumatic amnesia. Unconscious after a head injury is a serious condition because of the structural problem, whereas amnesia is only a physiological disturbance. So always check history from the observer also. Now the other type of patients coming and saying that ಅವ್ರು ಮಾತಾಡ್ತಾ ಇದ್ರು ಸಡನ್ ಆಗಿ unconscious ಆಗ್ಬಿಟ್ರು. Then you think that he has become unconscious, but he has not fallen down. He maintains the posture. You take the history from the attender, then they will say that she was conversing, suddenly stops, stares, unresponsive, chewing, champing movements lasting for about a minute. But the patient was unaware. So this is a typical complex partial seizure where amnesia for the event is there because of the seizure. The last of the amnesic examples are rare one, but to be remembered. An elderly person, hypertensive, diabetic, he had attended a marriage ceremony which lasted for 45 minutes. After returning home, he was not aware that he had been there and he attended the event also. So he was brought to the casualties saying that he was unconscious during the episode of the marriage ceremony. But actually, when you take the history, patient was completely normal during that episode, interacting very appropriately with everyone. Now this is called as a transient global amnesia, and usually the lesion is in the hippocampus. Hope you people are able to listen to me. Hello?
Yes, yes sir, we are able to listen.
You are able to hear me, right? So that is about the amnesia. So please remember, when a patient comes and says unconscious, make sure that it is really unconscious and not amnesia. Now when we come to the transient loss of consciousness, there are 3 or 4 common conditions. The commonest is syncope, or also called as fainting in the common language, blackout. Now among the types of syncope, the commonest is the vasovagal, then situational syncope, then orthostatic hypotension. The other differential diagnosis is epilepsy, psychogenic seizures, hypoglycemia, and very, very rarely TIA. Now let us look into the syncope. What is the definition of syncope? It is defined as a transient, self-limited loss of consciousness with an inability to maintain posture. I mean, this is very important point to differentiate amnesia from syncope. Because there is a postural tone is gone, it is followed by falling to the ground and spontaneous recovery. What is this due to? It is due to cerebral hypoperfusion. So as you know that the heart is at a lower level pumping station and the brain is a overhead tank. So due to some reason, the heart is unable to pump enough blood to the brain. There is a hypoperfusion which results in blurring of vision, that is a pre-syncope. And if it continues, then the nature wants the person to fall down so that the heart and the brain will come to the same level and they recover the consciousness. But many times in our enthusiasm to see that the person is sitting in the chair rather than on the ground, we continue to favor the hypoperfusion and the patient may continue to have unconsciousness. So please remember, whenever there is a patient of syncope, the first thing to do is to make the person flat on the ground, no matter how bad is the ground. Now, the vasovagal syncope is the commonest one. It is also called as a neurocardiogenic syncope. Earlier, we used to call it as a very simple term, vasovagal. Then it is called as a neurocardiogenic syncope. It is a benign condition, self-limited. Now, why is it called neurocardiogenic syncope? There is a stimulation of cardiac C fibers. In the cardia, the C fibers results in vasodilatation and increased vagal tone. That's why we used to call it as vasovagal. Now, this causes reduction in cardiac filling and bradycardia with ensuing syncope. And there is an exaggerated autonomic symptoms. And these are all responses to pain, fear, and panic. Now, this slide illustrates to you the various causes of syncope. For example, defecation and micturition syncope will stimulate the medullary region, what is called as a vasodepressor region in the medulla. Glossopharyngeal neuralia, swallowing, can cause syncope. Commonest is cardiac C fibers. Then cough, head turning, carotid massage again can stimulate the medullary region. Panic, fright, and pain can cause this. So the net result is an increased vagal tone and decreased sympathetic tone. That means there is a vasodilatation with bradycardia. See, normally when there is a vasodilatation, we expect tachycardia, but actually there is a bradycardia because of increased vagal tone. And this causes resultant of cerebral hypoperfusion and syncope. These are the various causes which ultimately results in vasovagal attack. To give you some example, in the school prayer meeting, a child who was standing in the prayer for quite some time, suddenly she fell down, had a few jerks in the limbs, and she was unconscious. Immediately she was shifted to the principal's room. By that time she regained consciousness. But the history was that she became unconscious and had myoclonic jerks, and a diagnosis of epilepsy can be made with this history. But look at the total history: standing, fall, unconscious, and then myoclonic jerks. So this is a syncope, vasovagal attack, not because of epilepsy. And then we have situational syncope. A 35-year-old male woke up from sleep, went to the toilet, standing and passing urine. So sudden change from supine to standing, and the patient having hypotension and bladder emptying further causes hypotension, and patient fell down and hit his head in the commode and got some injuries. If you just look at the story that he became unconscious, had injury, then one would have said it could be epilepsy. But if you take the whole picture into the consideration, then it is called as a micturition syncope. The treatment is to see that the person doesn't stand in future, sits on the commode and passes urine. The other causes of situational syncopes are cough syncope. It need not be necessarily several bouts of cough followed by syncope. It can be one severe bout of cough followed by syncope. Similarly, sneezing, swallowing, all these things can cause syncope. So what does this mean? When you find a person comes to casualty with a transient loss of consciousness, you should look into all these symptoms before he lost consciousness. Then you can make a proper diagnosis that this is a cough syncope or a sneeze syncope or micturition. Then we have the other type of syncope, occasionally carotid sinus syncope. Now, when the carotid sinus is stimulated in the neck, upper part of it, like wearing a tight bandgala dress or a tie, or even head turning while shaving, or massaging that part of the carotid artery for some reason, the patient may fall down unconscious. So that is a carotid sinus syncope, and naturally the treatment is to avoid those situations. And finally, we have orthostatic hypotension, where the patient, especially hypertensive on antihypertensive drug, gets up in the middle of the night, gets up from the bed suddenly to go to the toilet and falls down immediately. Now that is a typical orthostatic hypotension. This can also happen in patients not only from lying down to standing, but even from sitting for a long period of time, and suddenly when they stand, there may be fall of blood pressure, and then patient may fall down unconscious. Transient, obviously. Now, very important for physicians is the cardiogenic syncope. Now, as I said, this syncope is due to cerebral hypoperfusion. So the pumping station is the heart. So any cause or any related cause of cardiac, either the pumping, the contraction is less, like the ejection fraction, or there is arrhythmia, bradyarrhythmia, trachyarrhythmia, or because you people are very fond of syndromes, Brugada syndrome, which is an inherited ion channel disorder with abnormal ST elevation, which is a cause for people without BP, without diabetes, young people suddenly dying. One of the causes is Brugada syndrome. Now, when there is an elderly man who comes for syncopal attack, you must look for cardiogenic causes. We have another 10 minutes before the first session finishes. Now, here is an example of an elderly man,
Sir,
repeated episodes of syncope, and because the syncope lasted longer, because the recuperation of the heart was a little slower, the increased or furthering of the cerebral hypoperfusion causes a tonic-clonic seizure. So this is very important to realize that 20% of new onset seizures in persons above the age of 60 years is due to cardiogenic syncope. So please remember this point, that whenever there is a new onset seizure in elderly people, it could be due to cardiogenic syncope. But how do we make a diagnosis? Unlike seizure, they don't suddenly fall down with tonic-clonic seizure. They always have a history of blurring of vision. There is a sweating followed by fall to the ground, and then there is a loss of consciousness, at times culminating in tonic-clonic seizure. Whereas in epilepsy, they fall to the ground with tonic-clonic seizure. So the history is the one which tells you that this could be cardiogenic, and you need to investigate the patient for cardiogenic seizure. So with that, we have finished the syncope part of it. To recollect, we dealt with the vasovagal syncope, child standing in the class, situational syncopes, orthostatic hypotension, and not to forget cardiogenic. So now we move on to the second common cause for the transient loss of consciousness. It is very common to misdiagnose syncopes as epilepsy, because the moment you say the patient was unconscious and then he became conscious, then you think it is an epilepsy. And it is very, very important not to misdiagnose a syncope for epilepsy, because as you are aware, epilepsy is a diagnosis with a lot of socio problems and long-term treatment, as well as, you know, so the diagnosis of epilepsy means a lot of problems in the house for the patient, lot of restrictions, and long-term anti-epileptic drug therapy. Now, this is another way of looking at it. A patient came to us saying that he was standing, then he had a sudden loss of consciousness, and according to him, immediately he recovered. Now, if you take the history from the patient, obviously you will think of syncope. But then always you must ask the history from the observer. So when you ask the observer, he said the patient had loss of consciousness, cry, tonic-clonic seizure, postictal confusion, the whole lot for a classical seizure disorder. But why the patient told like this? Because he doesn't remember what has happened. So he thought he has got up immediately, but actually the patient had all these things. Again, the diagnosis is by not only from the patient, but also from the observer, which is very, very important. You should always call the person who has observed the attack before you make a first diagnosis of epilepsy. There are other types of epilepsies which may be mistaken for syncope. For example, there is a patient with frequent episodes of fall to the ground and unconscious, but there is no seizure. Even the person who is accompanying this girl who was in the college, they said she just fell down and got up immediately. Now, one can again think of syncope. But then, when you specifically ask, do you get myoclonic jerks in the upper limbs at other times also? Then the patient said, yes, there are many times where there was jerking in the upper limbs and the objects used to fall down. Now, the jerking of the lower limb is responsible for sudden fall to the ground, but patient does not lose consciousness, so immediately she gets up. So this is a epilepsy mistaken as syncope. Now, these are the differential diagnoses between syncope and seizure. The syncope is usually in the upright or when a patient is looking at blood or needles or something like that. Whereas a seizure, there is hardly any trigger, occasionally photogenic epilepsy. Yes. Syncope, gradually the patient falls to the ground, whereas in seizure it is sudden. Syncope, immediately as soon as they fall to the ground, they regain consciousness, except in cardiogenic, whereas seizure lasts for a few minutes. A convulsive jerks are possible, but a tonic-clonic seizure usually occurs only in epilepsy. Incontinence, tongue bite, post-ictal confusion, they are all not possible in case of syncope. Then we come to non-epileptic attack disorder. This is again a differential diagnosis for transient loss of consciousness. Now, the current terminology is non-epileptic attack disorder. Earlier, we used to say psychogenic, hysterical, conversion disorder, and so on. So what it means is it is not epilepsy. I mean, that's a very important point. It is not epilepsy, though it is an attack of clonic movements. So that's why it is called as a non-epileptic attack disorder. Now, this is an interesting case of mine. A 12-year-old boy, he had 4 episodes of unconsciousness in school and 1 at home. Now, just before becoming unconscious, he complains of giddiness, and then he lies down and is unconscious for 10 to 15 minutes. There are no seizures. Now, 10 minutes to 15 minutes is obviously not syncope. And he doesn't fall down suddenly, and there are no tonic-clonic seizures, so it is not a seizure. So 2 common conditions, syncope and epilepsy, is out. But because he was unconscious, he was referred for EEG, which showed some non-specific changes, and without proper history obtained, he was diagnosed to have epilepsy and levetiracetam. Now the detailed history revealed, very interesting, that his class teacher was demanding food brought by him in the lunch box, leaving him hungry. And also the teacher not only was taking away his food, he was demanding, next time when you go home, bring sweets, bring this dish, bring that dish, like that. So his mother was very, very happy that this fellow is asking so much of food. That means he's really interested to eat well. One day, he was so hungry because all the food was taken away by the teacher, and he felt weak and he fell down. The teacher then got scared. Then he gave him his own food, that means the boy's food. And this gave him an idea that if he falls down unconscious in inverted commas, then his food will not be taken away by the teacher. Now, how do you make a diagnosis? From the history, there is no sudden fall, there are no seizures. And to say syncope, he gradually lies down himself and he is unresponsive for 10 to 15 minutes. So you will have to get story more clearly from the attender, from the person who has seen. Now you may ask, sir, what about EEG? EEG shows some non-specific, like non-specific STT changes in ECG. What is this you have written? A gift from Zoom. I believe they are giving a gift now, so you don't have to disconnect. So what do we do now? Running out of your remove 40-minute time limit on your group to me. Love it. Achha, I thought it is leave it. Okay, so we continue. So that is a non-epileptic attack disorder. Now there are quite a few differential points between non-epileptic and epileptic. Again and again, I tell you students and my colleagues that before you make a diagnosis of epilepsy, be 100% sure. Don't put them on anti-epileptic drugs and with psychosocial problems. Non-epileptic attack is a attack. It is what is called as a person wants to draw the attention. It's called as attention-seeking disorder. So somebody will be there. It never occurs when the person is alone or when the person is sleeping. And usually there is a trigger like anger, panic, and patient lies down gradually, and the duration is not like seizure 1 to 3 minutes. And patient is conscious at that time. He may be actually vocalizing something, oh, nani uta beku, or something like that he will be telling. The relatives will say he will unconscious. You would ask him, was he talking something when he was unconscious? Then they will say, yes, they were talking like this. Back arching is very common in females. And then when you try to hold down the movement of the limb, the other limb starts. Most important, clinical, is the eyes are closed in non-epileptic attack disorder, whereas in epilepsy, a genuine epilepsy, the eyes are open. This particular point is 90% very much important to differentiate one from the other. So because non-epileptic occurs very frequently and lasts for several minutes, I usually tell the relative to record it on the mobile video and also observe whether the eyes are closed or open. Now, in case in non-epileptic, the eyes are closed, you ask them to try to open the eyes and they will resist. Now, that is another important point. Resisting the eye opening when contacted. Now, another important non-epileptic attack disorder, another patient of mine, just to tell you, a patient can have genuine epilepsy and also can add on the non-epileptic attack disorder. Now, this girl who had a right focal epilepsy, I hope I am audible to everybody. Hello? Hello? Are you able to hear? Able to hear? Okay, good. So she had right focal epilepsy, and because of the cysticercus granuloma, and then she continued to have the seizures were well controlled because the granuloma resolved. I was in fact planning to taper off the anti-epileptic drug. After being a seizure-free for quite some time, she suddenly started having a recurrent attacks of unconsciousness and seizures, which continued in spite of CT showing a healed granuloma. When I reviewed the diagnosis, it's very important, but we have to review our own diagnosis, where we have gone wrong. Then the history showed that the unconsciousness and seizures were prolonged 30 to 45 minutes as compared to the earlier 3 to 4 minutes. And important, the timing is she didn't want to go to the school. So at the time of going to the school, the patient started having this seizure. So the father thought there is a recurrence of seizure. So he just comes and says, Doctor, our mele fits bartada node. And then to confirm it, we did a video EEG, and then it was a non-epileptic attack disorder. So message is, whenever the pattern of seizure changes, particularly the duration, one should think of psychogenic seizure. Now we come to the last 2-3 slides. Hypoglycemia is another cause of another common cause of transient loss of consciousness. Please remember, senior citizens are taking anti-diabetic drugs, especially the drugs which can cause hypoglycemia. So unlike there are some drugs which does not cause hypoglycemia. So this patient had 2 to 3 episodes per week of episodes of unconsciousness lasting for several minutes. Of course, as you can make out that many of these patients, as a common sense, the relative will immediately put some sugar in the mouth. But unfortunately, if the person is unconscious, the sugar may trickle into the trachea and causing more problem. Now, how do we, by the time the patient comes to us, the glucose is normal, patient is conscious. So the important thing is most of these patients have facilities to do GRBS at home. So we tell them that during the episode of unconsciousness, you record the GRBS and it was 30 milligrams. And so the anti-diabetic drugs was adjusted. The message here is that you should record the blood sugar when the patient is unconscious. When the patient comes back to the ward or back to the hospital, by then it would have become normal. Lastly, we're talking about transient ischemic attack. This is one of the common mistaken diagnoses. Elderly man, hypertension, diabetes, transient loss of consciousness. It may be cardiogenic or it may be a syncope. But because he has got vascular factors like hypertension, diabetes, they immediately get a brain scan done, and almost invariably it shows lacunar infarcts here and there. So they presume that it is a VBI and put a lot of anxiety into the patient that this is a minor stroke, you are likely to get a major stroke and all that. Isolated, please remember, isolated transient loss of consciousness is never due to vertebrobasilar. Remember, the seat of consciousness is in the reticular formation in the midbrain. So the ischemia cannot be specifically to the reticular formation. There will be surrounding tracts will be affected. Third nerve, fourth nerve, corticospinal, cerebellar tracts, any of these. So unless the patient has, at the time of recovery from loss of consciousness, he has ataxia, hemiparesis, diplopia, etc., then only we make it as a diagnosis of TIA. And in a typical TIA, you will never see an infarct because it is a transient. It is a purely clinical diagnosis. Only when there is a structural changes, you will find. So the TIA and VBI continues to be a clinical diagnosis based on the friends. That is, in addition to unconsciousness, there should be some other brainstem localizing symptoms. Now to wind up, what is the clinical approach? History, history, and history. History from the patient, how it started, where it started, what situation it started, and history from the person who has witnessed the attack. More often you may get a wife or a son in the hospital, but actually the person who has witnessed may be a servant maid who is left at home. You must call the maid servant and ask the person what the history is. And you should look into all these points in the history which I have already told you. Examination at that time, most often it will be normal. If there is a head injury, you should look for it. If there is epilepsy, you should look for tongue bite as a telltale sign of a seizure. What investigation? Only after a clinical diagnosis. Don't blindly do an MR scan and all that. The most important is to do GRBS at that time. You may do blood chemistry. When you think of cardiogenic, you should work up the whole cardiac investigations, including people usually do a Holter monitor and they say, oh sir, Holter monitor normal. But Holter monitor is only for 24 hours. So it won't give you any answer. You must have a loop recorder. Most important, whether it's Holter or loop recorder, the patient must have experienced a episode of transient loss of consciousness. Otherwise, a loop recorder itself becomes of no significance. Where you suspect young patients having recurrent syncopal attack, when ECG, echo, Holter, loop is normal even in a young patient, then we should undergo a tilt table test, which will tell us about postural changes in the blood pressure and the heart rate. When do you do CT and MR? Very rarely, very, very rarely. As I told you, don't make a quick diagnosis of VBI and then do a scan. Scan may be normal in TIA in vertebrobasilar. Scan is normal. Scan is abnormal in many unrelated circumstances. These are all investigations without clinical diagnosis, misleading because these are all incidental findings. Periventricular ischemia, calcified granuloma, and cerebral atrophy, or lacunar infarcts, or even a right carotid stenosis. This is another problem. Whenever a patient has a transient loss of consciousness, they do all this and then do one carotid, then there is a carotid stenosis. They think carotid stenosis is responsible for a transient loss of consciousness. If you remember, the seat of consciousness is a reticular formation in the midbrain, which is supplied by vertebrobasilar territory, and carotid artery has nothing to do with transient loss of consciousness. So don't subject them unnecessarily to stenting and all sorts of things. Now, last two slides. There are 198 patients presented to emergency room with history of transient loss of consciousness. What was the final diagnosis? 40% vasovagal or psychosis, 29% had seizures. In spite of all history and other things, 13% we still don't know what is the cause. But remember, history and physical examination are sufficient for diagnosis in 85%. Another statistical data which comes through 1,419 patients, 76% had syncope and only 24% had non-syncopal attack, which included seizures and all. And the second commonest cause being seizure. The clonic movements, automatism, postictal confusion are important points to diagnose seizure. Now, this is from a recent study in 2010. So So not take home message. Anyway, now it is a take home because all of you are locked up and locked down in the home. Approach to diagnosis of transient loss of consciousness is largely clinical, history, as you know me. Think of this, all common neurological problems, epilepsy, syncope, movement disorders, headache of various types, dementia, TIA, and even stroke in the first few hours is purely clinical diagnosis. Without any specific investigations, you can make a diagnosis. So to sum it up, clinical neurology is supreme even today.